On behalf of my co-authors, it is my pleasure to describe translational findings from our first-in-human studies in AML and MDS, and to introduce a new first-in-human study in solid tumors for the bivalent T-cell engager AMV564. My disclosures. Immune suppression by tumors is induced in part through recruitment of MDSC. As these cells do not have the capacity for clonal expansion and are comparatively short-lived, their recruitment is continuous and dynamic. Furthermore, the activated adaptive immune system in cancer can induce myelopoiesis and immune suppression, with cytokines produced by activated anti-tumor T cells inducing MDSC that dampen the tumor-specific immune response. MDSC act locally and systemically to inhibit T cell activation and trafficking, and importantly, also inhibit other critical processes in anti-tumor immunity, such as the maturation and functionality of dendritic cells. We are addressing this problem using AMV564, a bivalent T-cell engager that engages T cells to selectively deplete immature immune suppressive myeloid cells via avid binding to clustered CD33, which clusters in lipid rafts when signaling. On immature myeloid cells, CD33 is a signaling receptor that promotes immune tolerance, but CD33 has no apparent functional role on differentiated myeloid cells such as neutrophils, activated monocytes, and dendritic cells. Indeed, as shown on the right of this slide, at clinically relevant concentrations of AMV564, there is little evidence of binding to neutrophils or activated monocytes as compared to MDSC or KG1 cells. However, as shown on the left, AMV564 drives potent depletion of MDSC with concomitant T-cell activation, as shown by the increase in the interferon gamma positive fraction of both CD4 and CD8 T cells. The activity of AMV564 is target dependent, shown in the middle panels, with both cytotoxicity and the percentage of actively proliferating T cells in the presence of target cells, such as KG1, being dose-dependent. However, there is little to no evidence of either cytotoxicity or proliferation with non-target cells, such as neutrophils and monocytes. As we've presented previously, in AML and MDS patients in phase 1 trials, AMV564 promotes not only the depletion of leukemic blasts, but also depletion of MDSC in both the periphery and bone marrow. This depletion is selective with no impact on monocytes and neutrophils. As the bone marrow is the site of disease in AML, the findings for MDSC in the periphery with therapy being generally consistent with those in the bone marrow were encouraging in planning peripheral blood monitoring for our next study. There is also evidence of T-cell increases in the bone marrow with repeated cycles of therapy. Further analysis of our AML and MDS cohorts led to the observation that in dosing regimens where MDSC were not controlled, we observed an increase in regulatory T cells, as shown in the left and middle panels, whereas control of MDSC was associated with control or even decreases in the levels of Tregs, as shown in the example on the right. This is consistent with published findings for the role of MDSC in promoting Treg expansion and differentiation. Taking what we have learned from AML and MDS, we've initiated a solid tumor study to evaluate the tolerability, exposure, and activity of AMV564, now administered via a single daily subcutaneous injection on weekdays for a 2 weeks on, 1 week off regimen. AMV564 was well tolerated, with low-grade injection site reactions and low-grade fevers being the most common adverse events, no cytokine release syndrome, and there is no use of steroid premedication. Preliminary analysis indicates a steady-state peripheral exposure at or well above the EC50 for the 15 and 50 microgram dose levels, and there is evidence of the expected flip-flop kinetics in both the PK and pharmacodynamic data. In addition, the initial lymphatic distribution associated with subcutaneous injection of a molecule of this size is favorable with respect to drug delivery to tumor-draining lymph nodes. For the pharmacodynamic analysis, the first question is evidence of MDSC control in solid tumor patients. We collected multiple time points and observed a dynamic profile of MDSC in peripheral blood. On therapy and over cycles of therapy, AMV564 treatment yields control of MDSC from their initial peak in cycle 1, and this is associated with decrease in Tregs for these patients as early as the first cycle of therapy. One exception is noted for a GE junction patient dosed at 15 micrograms, where there was lack of control of MDSC in cycle 1, also reflected in lack of control of Treg in this initial cycle. For the other patients, especially those with higher Treg at baseline, decreases of 35 to 70% of Treg are apparent. These data are consistent with the depletion of MDSC and relief of immune suppression by both MDSC and Treg. Another view of the overall change in the T-cell profile on therapy is shown here with a CD8 over Treg ratio for each of the patients at multiple time points on therapy. As might be expected for an all-comers population in a phase 1 study, with many of these patients having experienced multiple prior lines of therapy, the CD8 Treg ratio at baseline is mostly below that observed for healthy controls, which are shown by the green rectangle. However, there is improvement in the ratio for most patients on therapy, such as the small bowel cancer patient, with a steady increase in and across cycles, and the ovarian cancer patient with a rapid increase on therapy. While this study is early, we already see association of the improvement in the T-cell profile reflected in the clinical response, with several patients showing stable disease at their first scan and the second patient on study experiencing a complete response by RECIST criteria. The ovarian cancer patients experiencing a confirmed complete response had received multiple prior lines of therapy, including pembrolizumab, which was completed 6 months prior to initiation on this study. The longitudinal pharmacodynamic profile for this patient shows consistent improvement in the CD8 over Treg ratio, accompanied by an almost twofold increase in the CD8 T-cell fraction from baseline, increases in memory CD8 T cells, and affected CD8 T cells, as shown by the granzyme B and TBX21 positive fractions. There is dynamic modulation of PD1 positive T cells, but no general overall increase in the PD1 positive fraction. There is a notable early increase in the TBX21 positive CD4 T cells, consistent with the Th1 response. Overall, these data are consistent with dynamic polarization of T cells toward improved effector function and Th1 response, which in turn can drive anti-tumor immune responses. The peripheral cytokine and chemokine data also support favorable immune activation for anti-tumor immunity. While monitoring in the periphery represents a dilution of the signal being generated in lymphatic and tumor tissues, we nonetheless observed a 10 to 40-fold increase in peripheral interferon gamma, along with increases in soluble granzyme B, consistent with cytotoxic activity, and IL-15, an important cytokine for tissue-resident memory T-cell function, among other properties. We observe a subsequent wave of increases in critical tissue trafficking chemokines, such as CXCL9, 10, and 11, and 10 is shown here. And finally, IL-18, a key factor for dendritic cell activation and T-cell maturation. While the cytokine increases are mostly apparent in the first couple of cycles of therapy, we do see increases in later cycles as well, as shown in the upper right panel for both interferon gamma and IL-18 in the first 2 patients on study. As a reminder, despite all this evidence of activity, we do not observe any cytokine release syndrome in these patients. In conclusion, our observations for MDSC depletion in vitro, ex vivo, and in clinical studies continues to be supported in our ongoing phase 1 solid tumor study, with relief of immune suppression via depletion of MDSC, reduction in Treg, and polarization of effector CD8 and Th1 T cells with a cytokine milieu conducive to improved antigen presentation and T cell trafficking. Furthermore, we have seen evidence of clinical activity with ANB564 monotherapy in this first-in-human study of heterogeneous patients who are in later lines of therapy in their treatment journey, including a confirmed RECIST complete response in an ovarian cancer patient previously treated with pembrolizumab, among other therapies. And with that, I would like to express our deep gratitude to the patients and their families and our clinical trial investigators, sites, and staff, and thank you for your attention.